Hello and welcome to Sleep Review's webinar, Preventing and Managing Augmentation in Restless Leg Syndrome. I'm Sri Roy, editor of Sleep Review, and I'm here with three esteemed speakers, Drs. William Ondo, Daniel Lee, and Mark Bookführer. After the three presentations, we'll answer as many questions as we can live. Submit your RLS augmentation-related questions via the Q&A box on your screen. Also, the complete slide deck is available for PDF download via the slide download and links box on the right-hand side of your screen. The webinar is sponsored by Arbor Pharmaceuticals. For the AAST credit, the CEC is available for the live webinar only, which applies to you if you are watching Friday, March 23rd at about 9 a.m. Pacific time. Today's webinar is being recorded, but the pre-recorded version isn't eligible. On the registration page, you must also have said yes when asked about wanting the credit, which was the default. For privacy reasons, we won't be submitting the full roster to the AAST, only those who requested the credit. So you must watch all three presentations and complete the exit survey on the left-hand side of your screen. Even if you don't want the credit, we'd appreciate it if you'd take the survey. Once you take the survey, the form will simply close. If you don't get the certificate needed for AASD credit by April 24th, email me at sroy@medcore.com. Let's start today's webinar with an audience poll. Please select from the choices on your screen. Then click the Submit button so we include your response in the calculations. What I find most difficult in determining whether augmentation is occurring is differentiating augmentation from tolerance, rebound, night-to-night symptom fluctuations, symptom worsening due to another cause, or natural disease progression. Please select the one that applies the most to you. And it looks like our audience today has the needs the most help with differentiating augmentation with symptom worsening due to another cause. About 50% of our audience said that, and then the second most difficult one is differentiating it between night-to-night symptom fluctuations. That gives us a good feel for today's audience, and we think today's webinar will give you practical advice for differentiating between these experiences. It is now my pleasure to introduce William G. Ondo, MD. Dr. Ondo is director of the Movement Disorders Clinic at the Houston Methodist Neurological Institute, and he has been diagnosing, treating, and researching RLS for more than 20 years. Dr. Ondo earned his medical degree from the Medical College of Virginia, and then completed an internship at the University of North Carolina Hospital, a neurology residency at Duke University, and a movement disorders fellowship at the Baylor College of Medicine. He is board certified in adult neurology and sleep medicine. Welcome, Dr. Ondo. We're ready to hear your insights.
All right. It's a pleasure to be here, especially with my esteemed colleagues, both of which I've worked with for many years on this difficult topic. So I am actually a movement disorder background, so I'm not really I am sleep boarded, but my background for this is more from the movement disorder side and dopaminergic side. We started to use dopaminergic medicines in the early 1990s. Initially, they were just fantastic, but over time, we learned that they do have some definite long-term problems. So, since I'm the first speaker, I was going to give a 1-minute lecture on restless leg in general. RLS is still clinically diagnosed. There is nothing on examination that is part of the diagnosis of RLS. There's no PSG actually required to make the diagnosis of RLS. It simply involves talking to the patient. And they have to tell you at least 4 main things. There has to be some urge to move the legs, okay? And this can be described lots of different ways. Sometimes they'll say it's an urge, other times it's more of a sensory component, but it's not just a sensory component. So if you just have numbness in your legs and there's no urge to move, that's not restless legs. The second and third things are related. The symptoms are worse with inactivity, and they at least transiently improve with physical activity. So they'll tell you they get up, they walk around, they move, they kick, etc., and these things improve the RLS. And then finally, there does seem to be a true circadian pattern of this. It's not just a function of activity. Symptoms are worse in the evening and nighttime, and perhaps most robustly, symptoms are improved in the morning. So it's very rare to have RLS at 7 a.m. unless people do have augmentation, which will be the crux of this discussion. Okay, and that's really it as far as making a diagnosis of restless legs. Again, no PSG required. You don't even need an examination. It's just if they say those 4 things, they have restless legs. Now, treatment options. We have a number of different treatment options, and this finishes up my lecture on RLS. First of all, patients will do sensory stimulation, so hot baths, vibrating pads. Pain in the legs, hitting yourself with a baseball bat will improve restless legs. Usually not a good strategy to get to sleep. Really, vibrating pads are, I think, the only option, and I think they're okay for mild symptoms, but when you get more severe, then they are certainly inadequate. Dopaminergics is what we'll talk about mostly here because they seem to be specifically associated with augmentation. Levodopa was the first tried in the 1980s, and that has horrible augmentation. And then the dopamine agonists, which we mostly use these days, pramipexole or Mirapex, ropinirole, Requip, retigotine or Nupro patch are the 3 that are all FDA approved in the United States for the treatment of restless leg syndrome. So briefly, some of the other options, the alpha-2 delta ligand drugs, these are the gabapentin type drugs. Gabapentin enacarbil or Horizont is the one that's actually FDA approved for restless legs. And then pregabalin or Lyrica also has strong data showing efficacy. As a rule of thumb, these medicines are better at getting rid of sensory component, not as good at getting rid of the pure urge and actual periodic movements of sleep that are associated, but they are also somewhat better at sleep architecture, where they increase slow wave sleep, whereas the dopaminergics, overall, it's kind of a push on what they do to PSG studies. Next option, opioids can be very effective, especially the mu-opioid drugs like methadone, which is kind of a fallback drug for us. Obviously, those are never going to be first line for patients because it is chronic therapy, but I think sometimes they are actually underused in this population. And then most recently, there's been tremendous interest in intravenous iron. Oral iron is okay, but if you have roughly normal iron levels, you don't absorb that pill at all. It's a total waste of time. If you're severely iron deficient, you do absorb the pill, but because of that, we give intravenous iron, and there is increasing data that this can be very effective, especially after a delay. It often seems to take 4 to 6 weeks to have its peak effect. But it's the dopaminergics that are associated with augmentation. So everyone knows that augmentation is a general worsening of symptoms, but when trying to figure out the best way to describe this, I sort of came up with what is not augmentation first, and this first question kind of alluded to this. So what are things that can make symptoms worse that really are not augmentation? So the first is tolerance. Almost any neurologic medicine can have tolerance. This is a scenario where they have RLS at 10 p.m. They took the pramipexole 0.25 milligrams at 9 p.m. For 6 months, there was just no symptoms at all. But now at 10 p.m., they're having a little bit of symptoms. So this would be tolerance. There isn't an earlier onset of symptoms or anything along those lines. You can have just a lack of effect because the drug is not in the system. So based on pharmacokinetics, levodopa is the big culprit here because it has such a short half-life. You take levodopa, someone has symptoms from 10 p.m. to 2 a.m. Normally, you take levodopa at 9 p.m. and until midnight they're fine, but at 1 a.m. they're having symptoms. Well, that's because there's no levodopa in the system anymore, okay? So that's just a pharmacokinetic issue. You can have, of course, worsening of RLS secondary to other causes. Antihistamines as an iatrogenic cause are probably the main culprit here, especially sedating antihistamines. So diphenhydramine or Benadryl is probably the worst as a drug that worsens restless leg syndrome. Dopamine blockers can worsen it, and they sneak up on people as nausea medications. And of course, iron loss. If they're, this is on neurology board exams now, what evaluation do you do if someone has acute onset restless legs? Well, you look for blood loss or iron loss because this can result in an acute worsening. And then, of course, situational. If someone is forced to be immobile, they're going to have restless legs. So they had a knee replacement and now all of a sudden they can't walk or they're in a cast, you certainly might get a worsening in that scenario. The most difficult to sort of differentiate from augmentation is Well, is the disease just getting worse over time? And we do know, as a rule of thumb, over decades, at least into like 80 or so, when it seems to level off or sometimes even improve, there does tend to be worsening of RLS symptoms. So you certainly could get an earlier onset of symptoms or so forth, just based on natural disease progression. And I don't really know how to definitively sort that out. Okay, so augmentation does have a number of formal diagnostic criteria. There's 5 in the literature. They are very similar, so I wouldn't get too worried about which is the best. The Max Planck criteria has actually been used in several studies, so I'll actually outline that. But again, all of these criteria were just made up by a group of people who are experts in RLS. None of them have any definitive sort of biomarkers to substantiate them. Okay, so definition, augmentation. So it's a worsening of symptoms after the initial therapeutic benefit. It again is essentially, there's a little bit of debate of whether you can say this, but essentially confined to dopaminergic medications, okay? And there are some case reports of a few other drugs causing augmentation, but it's strongly associated with dopaminergic medications. So in this definition, they had a couple of different distinctions. One, if you had an onset of 4 hours earlier, that was enough. Okay, so if you normally have symptoms at 10 p.m. and now you're having symptoms at 5 p.m., that in the setting of drug use, of dopamine agonist use or dopaminergic use, that's considered augmentation. Or you could define it by a shorter duration, earlier onset of just 2 hours, as long as they had some other feature of worsening RLS. So they could have a shortened or late, as soon as they lie down, it happens, that's much faster. You can get extension to other body parts. So arm involvement is fairly common in people that are augmented and have had RLS for many, many years. You could just get a worse intensity. I mean, when it does happen, it was worse than it ever was before. Or you can get, less relief from some walking. So I used to get up and walk for 5 seconds and it was better. Now it takes me like 3 minutes of walking before it improved. So this is a very, formal criteria. But the key really always in all these definitions, you have to have an earlier onset of symptoms. So you're somehow shifting the circadian clock and maybe an earlier onset of symptoms than they ever had before. That's the key feature for augmentation. Intensification of other symptoms are often seen. Okay, so how common is this? Well, there's a couple of different data, but no one's ever really done a definitive 20-year prospective study on dopamine agonists. There is very good data out to about 1 year, but after that, the quality of the data really drops off. I think most of the preponderance of evidence, I would say there's one study that's 4% per year, but most people would say 5 to 10% incidence, which seems to be cumulative. It does seem to be fairly linear. The longer you're on the medication, the increased risk of augmentation. Now, one of the data sets that I like actually didn't look at augmentation specifically, but it looked at dropouts. And this is from the Johns Hopkins group. And there's 3 different drugs they're looking on this graph. If you go down to the x-axis, this is about 12 years of data. Okay, so it's in days there, but about 12 years from one end to the other. The green line is pergolide. So this is, some of this data is pretty old. We rarely use pergolide these days. And the yellow line, though, we're all familiar with, is pramipexole, and the blue line actually is methadone. So this is actually a study looking at methadone. But these were drops, okay, so survival curves. Now, at the beginning, lots of people drop because of adverse events or loss of efficacy. But after a few months, almost all the patients on the dopamine agonist lines dropped out because of augmentation. And you can see it's relatively linear over time for both the pergolide, which seem to have even higher augmentation, and there are some theoretical reasons why that might be the case, and pramipexole, which still, again, has much less augmentation than levodopa, but all the dopamine agonists still do have augmentation. So this is, I think, nice data. It's dropouts, it's a survival curve, but about 90% of them dropped out because of augmentation. That's as good as any 10-year data set that I've ever seen looking at this. Okay, so what are some of the risks? So duration of treatment is number one, okay, and certainly, being on a dopamine agonist, I guess, is number one, but duration of treatment is number two then. Now, after that, there's a little bit of, in my mind, controversy about dosing, and I saw some of the slides coming up that they do advocate a lowest dosing, but there's not really definitive data in my mind that higher dose definitely correlates with augmentation. There's strong indications of that, but people are on higher doses because they have more severe RLS as well. So it's not clear whether it's the dose or the initial severity of the disease that's more the independent predictor of RLS, but clearly bigger dose does correlate with increased risk of augmentation, and there is one prospective trial, for 48 weeks or so that does suggest that as well. In some of the other studies, having a family history of RLS turned out to be a risk factor for developing augmentation sooner. Lack of neuropathy which also sort of goes along with a family history of RLS, seemed to be a risk factor for augmentation. In a couple of studies, low iron seem to be a risk factor for augmentation. So this is another potential preventative treatment that will be discussed shortly, and an argument for more aggressive iron supplementation in any RLS patient. And then there is some suggestion that the shorter-acting dopaminergics like ropinirole may have more augmentation than longer-acting dopaminergics like a Nupro patch or rotigotine patch. But that also may be the fact that you're already treating the augmentation. So we don't know if there's really a change in the physiology or whether it really is just the fact that they're getting the augmentation, but you're already treating it by giving them a drug earlier on. So that one still also is a bit of an open book in my mind anyhow. All right, what causes augmentation? Last couple of slides here, and this is largely speculative, okay? We don't know. We don't know exactly what causes augmentation. I mean, clearly everyone thinks there's some sort of alteration in dopamine receptors, but you get alteration in dopamine receptors within days of taking dopamine agonists. And obviously for most people it's, a number of years or at least many months before they develop augmentation. This gets to the bigger question. We don't truly understand what causes RLS. Me and many other people feel that the dopaminergic component of this is in the brainstem, and it goes down into the spinal cord, where there are dopamine tracks, very small number, but they go into the spinal cord. They've been involved with autonomic features. They've been proven to be involved with periodic limb movements of sleep, and they also seem to be involved with suppression of sensation. So these are all things that make a lot of sense that go into that are associated with restless legs. There's two main types of dopamine receptors, D1 and D2. All the drugs that treat RLS are D2 agonists and also D3 agonists, although there was a pure D3 agonist that failed to show benefit. So we think you at least need some D2 agonists to improve restless legs. Now, again, to make a long story short, in some of the animal data that we've looked at and some modeling of restless legs, it turns out that with chronic use of dopamine agonists, you upregulate to some extent D1 receptors. And D1 receptors do the exact opposite of D2 receptors, not only in the spinal cord, but also in the basal ganglia. So dopamine's very interesting that way, and that does the opposite things in different receptors. So we've postulated that augmentation is associated with gradual upregulation of D1 receptors. This is a speculation. I mean, I can't prove this in any way, shape, or form, but we are looking at this now in humans where we have started a trial of a specific D1 antagonist for patients currently taking dopamine agonists and have had augmentation. So we'll get results of this in about 6 months or so. We are very excited about it. But bottom line is, no one can tell you the exact mechanism of action of augmentation. Okay, so in the next subsequent lectures, you'll hear a little bit more about more practical things that you can do to try to prevent this, and the most difficult scenario is what you do in patients that you see that already have augmentation, because there really are no easy answers for that, but there are a number of strategies that will be discussed. So with that, I think I'll turn it over for an audience poll question.
Thank you so much, Dr. Ondo, for that insightful presentation. And as he alluded to, here is the second of our 2 audience polls. Again, please click Submit to ensure your response is counted. Thinking of the patients with RLS currently in your care, about what % of them entered your care after they already began experiencing augmentation? For example, a patient referred by a primary care physician after some treatment was initiated. You have a few percentage options on your screen to choose from. Now let's take a look at the results. It looks like most of you say about 0 to 25% of the patients currently in your care had augmentation when they arrived at your doors, and the second largest group is saying 25 to 15% of the patients were already suffering from augmentation. On that note, the next 2 speakers will be discussing preventing and managing augmentation. The first of those 2 is Daniel Lee, MD, FAAN, FAASM, who is the Medical Director of the Sleep Research Center at Baptist Health System in Kentucky. He is board certified by the American Academy of Neurology and Psychiatry and the American Board of Sleep Medicine. His major research interests are circadian rhythm physiology, genetic engineered dopamine 3 gene knockout, and pharmacologic therapy of RLS. Dr. Lee has published extensively in peer-reviewed medical journals and served on the National Scientific Advisory Board of Willis-Ekbom disease research. He is commissioned as Kentucky Colonel by Kentucky Governor for Distinguished Service and Accomplishments, the highest honor awarded by the Commonwealth of Kentucky. Welcome, Dr. Lee. We're ready to hear your experience.
Thank you so much, Sri. And let's have the first slide here. Augmentation is increasing at an alarming rate of 8% per year since the introduction of the first dopamine agonist by the FDA in the treatment of restless leg syndrome in 2005. And higher the dose and longer the duration of treatment with dopamine agonist, the risk of augmentation increases. So when the restless leg patient who had been stable on treatment and began to experience worsening, especially after dose increase, then one need to consider the diagnosis of augmentation. In the South here in Kentucky, we call it backsliding. The Max Planck diagnostic criteria can be summarized with the mnemonic SLIDE, S-L-I-D-E, that I often use to help my medical students and residents to remember the diagnostic criteria. S stand for spread to the other extremity instead of lower extremity, now going to the trunk and upper extremity. L stand for latency of symptoms, is shortened at rest. Instead of having restless leg symptom an hour into the NCAA basketball game last year, now 15 minutes into the game and you start experiencing the symptoms. I stand for intensity of symptoms, are greater than pre-treatment level or no treatment at all. D stand for duration of efficacy of the dopamine agonist is shortened. E stand for earlier onset of symptoms by 2 to 4 hours. Instead of having the symptom at 10 o'clock in the evening, now they may be having it at 8 o'clock. Some of the strategy can be helpful in preventing augmentation, include supplementing iron that Dr. Ondo already alluded to when ferritin level is less than 75 or the transferrin saturation is less than 20. Avoid sleep deprivation or alcohol use. Medications such as antihistamine and antidepressant can be the contributing factor of worsening of restless leg symptoms. In some of the patients have restless leg symptoms is improving on dopamine agonist, one may consider reducing the dopaminergic load by using the lowest possible dose for the shortest period of time, but always never exceed the maximum recommended dose for the treatment of restless leg syndrome. In treating de novo patient, one should consider non-dopaminergic medications such as alpha-2 delta ligand, and the only alpha-2 delta ligand being approved by the FDA currently is Horizons or gabapentin and acarbol. If patients have mild symptoms, one may consider intermittent dosing, such as using 1 to 2 times a week. The goal here is not to completely eradicate all of the RLS symptoms, but to ensure the quality of life improves with those patients. If a patient is on short-acting dopamine agonist and begin to experience augmentation, one may consider switching to a longer-acting dopamine agonist, since some studies suggest the use of long-acting dopamine agonists may cause less augmentation. What do we know about the science of augmentation? Let's first review what we know about Restless syndrome. We know that diabetic patient, pregnancy, aging population, genetic predisposition, iron metabolism dysfunction, female patient, dopamine dysfunction, basal ganglia dysfunction have been implicated in the pathogenesis of Restless syndrome. But today we're going to look at the dopamine dysfunction in the spinal cord region. We are all very familiar with some of the dopaminergic pathway, including the nigrostriatal pathway. We all learned this in relationship to Parkinson's disease. Mesocortical limbic system, especially we also call it the reward center. Tubuloinfundibular pathway, especially in the treatment of prolactinoma. And probably one of the most important pathway is the diencephalospinal pathway, projecting from area 11 throughout the entire length of the spinal cord. And there are numerous collaterals in the sensory, motor, and sympathetic area of the spinal cord, thus allowing dopamine to exert its modulatory effect in these specific areas. The highest density of D3 receptors are located in the dorsal horn, providing the inhibitory modulation in this sensory processing area. Dopamine has the highest affinity to D3 receptor. I call the D3 receptor is the lord of all dopamine receptors. So even at very low dose dopamine will be enough to activate the D3 receptor, whereas D1 receptor activation will require much higher dopamine level. Spinal neuron may be able to react in a dose-dependent manner to dopamine. At low level of dopamine, D3 receptor is activated. It will trigger an inhibitory modulation, as I mentioned earlier. But at high level of dopamine, it will induce an excitatory response through the D1 receptor. So a potential model in the understanding of restless leg mechanism would include C fiber deep in the muscle project nociceptive signal to the dorsal horn and there to the thalamus. Sensory and motor component in the spinal cord are under the inhibitory control from the descending dopaminergic fibers, originally from the area 11, A11. Now, if there is a dysfunction in this descending dopaminergic system, will allow the disinhibition of the spinal sensory motor network. D3 agonists will provide an inhibitory modulation of this sensory signal. Restless leg patient, when pacing the floor, will activate muscle stretch receptor, which in turn activate an inhibitory gate in the dorsal horn, thus terminating the discomfort or the urge to move experienced by the restless leg patient. Numerous studies have shown that D3 receptor often form heterodimers with the D1 receptor, providing the off and on switch of the dopaminergic system respectively. Immunofluorescent GFAP stain in this region show a D3 and D1 receptor are co-localized in the same region, further support this possible hypothesis. Long-term D3 receptor agonist treatment would increase D1 receptor protein expression in mouse model in our laboratory, which suggests a possible role of D3-D1 receptor interaction may play a role in our clinical observation of augmentation. So initially, when restless leg patient was treated with dopaminergic medication, D3 receptor was activated to provide symptomatic relief. But higher dose and the longer duration of treatment with dopaminergic medication, the augmentation risk increases, possibly due to the excitatory D1 receptor being activated. So a potential solution to tackle augmentation may be a combination of D1 antagonist with D3 agonist. In our mouse model, a combination of D1 receptor antagonist with D3 receptor agonist provided physiologic improvement in augmentation, but further study is indicated. like Dr. Ondo has talked about. In summary, augmentation is increasing at alarming rates. This inhibition of the spinal D3 system may play a role in the sensory symptoms experienced by the restless patient. Our finding also suggests that D1 receptor may play a role in the augmentation that arises with the long-term treatment with dopaminergic drug. While D1 receptor antagonist in combination with D3 receptor agonist may be beneficial in animal model, combating the sensory symptoms of augmentation. But for now, physicians should treat de novo patients using non-dopaminergic agents such as alpha-2 delta ligand. If patients have mild symptoms, one may consider intermittent dosing with dopaminergic medication of less than 1 to 2 times a week, or use the lowest possible dose for the shortest period of time, but always never exceed the maximum recommended dose of dopamine agonist for the treatment of restless leg syndrome. If a patient is on short-acting dopamine agonist and begin to experience augmentation, one may consider switching to a longer-acting dopamine agonist. When examine ferritin level and transferrin saturation level, and be prepared to supplement iron when needed. Thank you very much.
Thank you, Dr. Lee, for the wealth of scientific insights. Now a word from our sponsor, Arbor Pharmaceuticals. Arbor Pharmaceuticals is an Atlanta, Georgia-based specialty pharmaceutical company that provides prescription products for the cardiovascular, hospital, neuroscience, and pediatric markets. Arbor is proud to be a corporate sponsor of nonprofit organizations that provide disease state information. Arbor believes in being a good corporate citizen by doing its part to help associations that focus on funding discovery of new medicines or helping people afflicted by diseases. To learn more, visit arborpharma.com. I'm pleased to introduce Mark Buchführer, MD, who is a pulmonologist, sleep specialist, and expert in restless leg syndrome. He sees restless leg syndrome patients at his private practice in Southern California. He also practices at the monthly Restless Leg Syndrome Clinic at the Stanford Center for Sleep Sciences and Medicine, which has been certified as a quality care center by the Restless Leg Syndrome Foundation. He is the medical advisor of a Southern California RLS support group. Dr. Buchführer has authored and co-authored several books and medical articles on RLS, including a 2016 consensus publication presenting guidelines for the prevention and treatment of augmentation. Welcome, Dr. Buchführer. We're ready to learn from your expertise.
Okay, thank you. We're going to talk about the treatment of augmentation. I'm not going to say too much about my first few slides, which are the criteria, which you've already heard. The NIH criteria is the one most of us use, and I won't go over these slides. There's also the Max Planck Institute criteria, which we use more for research. Very complicated, but I'm going to give you my simple rule. Whenever you see a patient that's on a dopamine agonist, with persistent worsening of their restless leg symptoms, think of augmentation until you prove otherwise. And if you use that rule, you'll probably pick up a lot more augmented patients. I can tell you most of us who are the kind of national restless leg consultants, the go-to guys, we see over 75% of our consults are augmentation patients. And of course, you want to rule out conditions that may cause similar symptoms to augmentation, and I won't go over those. Those are listed and have been discussed before. So I'm going to talk about the kind of practical treatment of what you do when you get an augmented patient, and this is the algorithm that several of us, including Dr. Ondo, the first speaker, put together in a consensus paper a couple of years ago. And that's easily available, so you can use that as a reference. This is the full algorithm, and I'm going to go over this piece by piece, so it's not quite as difficult as it looks. If you see the augmented patient, first you want to eliminate exacerbating factors, and of course, you look at the iron levels. as represented by ferritin. And if they're low, you can try to supplement them by oral or often intravenous methods, which are very helpful. Lifestyle changes. Sometimes patients may be more sedentary, and there's things you can do. And, of course, exacerbating drugs. All the things the other two speakers spoke about at length. So we divide augmentation into mild augmentation on the left box and severe. Severe is very simple. It's everything that mild is not. And we'll go over what that means in a few minutes as we go through the slides. The basic thing with mild augmentation, most of these patients just have an earlier onset, usually 2 or more hours. The dopamine dose is less than the maximum dose. And just let me say that almost all the patients I'm seeing these days that are referred are on doses way higher than the maximum dose. So I caution everybody to keep the dose within the reasonable limits when you're treating with a dopamine drug. These symptoms usually cause only mild distress. The patients aren't that put out by the symptoms, and they can usually tolerate them at that point. And there's been no previous increase. Once the patients have achieved a steady dose, they haven't had any increases since then. So once you have to increase it after a stable period, that's, of course, as I said before, when you think of augmentation, and at that point it's still in the mild category. Now, what do you do then? The goal would be to keep the dopamine agonist dose at the same dose if possible. You have 2 strategies. One is you can split the dose. So, for example, if the patient is on ropinirole or Equip at 1 milligram, you can give half earlier to take care of the earlier onset and half later. Or you can just give the whole dose earlier, which sometimes works. Now, if these option fails, then you can increase the dose, but you want to keep it still below the maximum approved dose. I often say at this point you may want to consider using other strategies because with time the RLS augmentation process tends to get more difficult to treat. So the earlier you're treated, probably the better. So if those strategies fail, you go to the complete switch, which is in the right-hand boxes, and you have 2 options. You can switch to an alpha-2 delta drug, which we discussed before, the gabapentin or Horizon or pregabalin, which is Lyrica, or you can try to switch to the longer-acting dopamine drug, which is retigotine or the Nupro patch. That's the only approved one. There's others available, but typically those are at higher doses, which we often don't like to go to. Now, if those strategies fail, then, of course, you're dealing with more severe augmentation. And as we said before, severe augmentation is everything that mild isn't. The symptoms are more severe, or you haven't responded to the treatment for mild augmentation. Now, the objective here is to get the patient off the dopamine drug if you can do that, or if you can't, at least to reduce the dose. Sometimes that's helpful, but we believe that if you can get the patient off, it may be much easier to treat their restless legs. And, of course, we want to switch them to either a drug like Horizon, retigotine, or the Nupro patch as a long-acting dopamine agonist. So you have 2 choices here. And I'm going to talk first about the, this is the boxes now below I'm going to, the one on the right, the 10-day washout. This is something they do a lot at Johns Hopkins. This can be very challenging both for the doctor and the patient because when you stop the dopamine drug, especially in an augmented patient, the RLS gets markedly worse immediately. And especially if you don't give anything else to the patient, they may not sleep for 10 days or so. It could be a week, could be 2 weeks, sometimes even longer. This can be very tough. They will often call the doctor several times, sometimes per day, and it's a tough period to get through. The advantage of using this technique is that after 10 days, the RLS usually gets a lot better and may be easier to treat, and you may be able to institute medications such as an alpha-2 delta ligand, like Horizon, or possibly opioids at lower doses than you might have if you hadn't gone through the washout period. But again, this is very challenging, and I haven't had too many patients who've been able to go through this. I've had a few really motivated patients who just don't want to use any medications at all, and they've taken time off from work and just dedicated a 10-day period. But trust me, this can be very, very difficult. So next we'll go over to the cross-titration, which is the box on the left. And here what you do is you add an alpha-2 delta drug while you're gradually reducing the dose of the dopamine agonist. And how fast you reduce it depends on the dose that they came in on. The trouble with this is once you get down to lower doses, it's going to be very similar to the 10-day washout. And although the alpha-2 delta ligands are very good drugs for patients who are naive to treatment, they may not work as well once a dopamine agonist has been on board, but especially for patients who are augmented and you're trying to get them off the dopamine agonist, as we're trying to do here, they may add a significant amount of relief, but near the end when you stop the dopamine agonist, it may not be too dissimilar to how patients feel on a 10-day washout. So some patients may do very well with that, especially patients who come in on lower doses of the dopamine agonist, but I find with the higher doses of the dopamine agonist, when you stop them, these patients are very tough and will have several days where even with an alpha-2 delta ligand on board, they may not be able to sleep very well, if at all, and have a very difficult time. The other strategy is to switch from a short-acting dopamine agonist to a long-acting one, and we only have one that's approved, the Nupro patch. The difficulty I have here is most of the patients who get referred to me are already well beyond the approved doses of their short-acting dopamine agonist, and to switch them over to a long-acting one, you have to go above the approved doses of the long-acting dopamine agonist, the Nupro patch. And I generally don't like to do that because then the augmentation seems to come back. And it's a little difficult here. We're not sure whether we're really treating the or preventing the augmentation or just treating the earlier symptoms. So this is a little tricky, but again, many of the patients I have, just using this strategy alone can be difficult because they're already on very high doses of their dopamine agonist. So when these strategies fail, we go to the bottom box, and these are the majority of the patients that I tend to see. They're already on very high doses of the short-acting dopamine agonist, and trying any of the above strategies may be very difficult, or they've already been tried by their previous physician. So what we do here is we take them off the dopamine agonist, and if they're on a low dose, you can sometimes go cold turkey. If not, if they're on a higher dose, you can just taper slowly over a week or 10 days, while adding a potent opioid like oxycodone or methadone. Just for reasons of how well it works, many of us usually will start with methadone first, but either drug is probably quite reasonable. Again, if their serum ferritin is low, you would also want to supplement with intravenous iron, which is something we do quite frequently if it hasn't already been done. But these patients typically can be transitioned to a drug like methadone or oxycodone. They will typically need a higher dose for the first 10 days that they're completely off the dopamine drug. And then after about 10 days, and again, it could be a week, could be 2 weeks or longer, they will start to be able to taper down on the opioid, and typically they end up on fairly low doses of the opioid. And what you want to do after that is variable. If they're on a fairly low dose of an opioid, they may just want to stay on that, especially if they have no side effects. Sometimes we may add an alpha-2 delta drug, and that will enable us to reduce the dose, the maintenance dose of the opioid. Sometimes we may even have to add a small dose of a long-acting dopamine drug like rotigotine. Again, the strategies can vary here, but the bottom line is most patients who you treat with this algorithm should do fairly well and end up on a fairly good regimen that keeps them out of trouble for many years. So that's basically my presentation, and I think we'll leave it now to Sri, and I guess there's maybe a Q&A session also.
Yes, absolutely. And thank you, Dr. Bookfuhrer, for an excellent presentation and an important algorithm. We are about to begin the audience Q&A. If you're enjoying today's webinar, subscribe to email notifications about future events at www.sleepreviewmag.com/subscribe, where you can also sign up for a free print magazine subscription. This is a good time, if you haven't already, to use the Q&A box on the left-hand side of your screen and type in your question and hit submit. We'll get to as many as we can during this Q&A. The first question, which I will send first to Dr. Bookfuhrer, is who on your care team handles the urgent needs of patients who are coming off of dopamine agonists and having a hard time with that?
Sorry, can you repeat the question?
Oh, sure. Who on your care team handles needs of patients who are coming off of dopamine agonists and having a hard time? Do you handle it? Is there a nurse? Who handles those phone calls?
Okay. Basically speaking, the nurse may field the initial question, but typically it has to go to me because these tend to be very complex. And when you're doing the weaning off dopamine agonist process, sometimes you don't get many questions. Sometimes I don't hear from the patient until I see them back roughly in a month or so. But with the, I'd say, 10, 15% of more difficult patients, it's not uncommon to get a few calls per week or more.
Excellent. Would anyone else like to weigh in on that before we go to the next audience question? Dr. Ondo, I'll send this one to you first. The audience question is, by what mechanism do antihistamines worsen RLS?
Yeah, good question. I don't think anyone would say definitively. As a rule of thumb, anything that sedates you or makes you tired can worsen RLS until you get to the point where it completely knocks you out. Antihistamines in general are, again, inhibitory in the central nervous system, but the exact role with dopamine is a little less clear. I've looked into this, and I'm not sure if Dan knows anything otherwise, but we haven't found a whole lot of interaction between dopamine and histamine neurologic systems. But the key thing is it has to be into the CNS. So sedating antihistamines are sedating because they cross the blood-brain barrier and do get into the CNS, whereas non-sedating antihistamines are non-sedating because they don't get into the brain. So that's so it is a brain issue because it's really the sedating ones that are clearly worse than RLS.
It's a very interesting observation.
Mm-hmm.
Yeah, I'm sorry.
Go ahead. I was about to ask
It's a very interesting observation. Yeah, it's a very interesting observation. And those medication normally that help patient to, fall asleep, people use it like Tylenol PM, they have Benadryl base, and then tricyclic medication. All of those medication actually keeping the patient have restless leg syndrome more awake and alert in the nighttime and almost like unmasking those restless leg symptoms. So sometimes the patient, when they come to see me in the clinic, they say, well, my symptoms is a lot worse after my family doctor put me on some of the sleeping aid. And so that kind of make me thinking, hey, we may need to look into the restless leg symptoms. So, I think is a great observation to have.
Great. The next audience question, and Dr. Lee, I'll send this to you first. Can you review how ferritin affects dopamine regulation?
Yeah. Well, what's happening is the iron mechanism, and there are a couple of thoughts about that. I think that Christopher Early at the Hopkins Group had done a lot of work with the iron metabolism and how it can cross into the central nervous system. And we also know that iron is a very important cofactor for the dopamine synthesis. And we know the rate-limiting step for dopamine synthesis is tyrosine hydroxylase. Almost like this is like the turnkey, the cofactor for the tyrosine hydroxylase to make dopamine. And so, without the ions into the central nervous system, that might be one of the mechanisms that giving rise to the restless leg patient. And Bill, if you have some other things that you want to add, you can chime in too.
Yeah, there's a few hypotheses. No one knows for sure. The other one is that iron activates thymine marker protein, which also seems to facilitate the release of dopamine and other monoamines. So in theory, if you don't have enough iron, you don't have to activate a form of this protein, you can get a reduction of dopamine release, even though it's not impacting the amount of dopamine. That's always made a lot of sense to me because there isn't any clear evidence of reduction of dopamine per se in restless legs. Now, we don't have the fidelity to look at some of these smaller areas that go down to the spinal cord, but at least in the basal ganglia, areas associated with Parkinson's, there's never been much evidence of reduced dopamine.
All right, the next question is, and Dr. Ano, I'll send this to you first. Are essential tremors related to RLS or periodic limb movements of sleep?
Well, it's good you sent it to me because I'm the only one that believes they are. Yeah, we did a study where we found 100 consecutive ET patients because I'm a movement disorder guy, and 33 of them had RLS. Now, only about 2 of them were diagnosed with RLS. So these were patients that presented with tremor and usually had mild to moderate restless legs. But the interesting thing was many of them had a family history of both. So we went to the family histories, looked into it. They often had some people with tremor and some people with restless legs. So there's been no evidence of people that present with RLS that if you do an exam they have much tremor. But if you see a lot of patients with tremor, many of them do have mild, moderate RLS. That's how I can leave it.
Whoops. Okay, let me push another question to the slide area. And Dr. Lee, would you be able to weigh in on this? Is RLS a precursor to other conditions?
Well, restless leg syndrome, as I mentioned earlier, is a D3 problem. When I go around the country and give talks, a lot of time people was asking, is it related to the Parkinson's disease? We know that there are so many different dopamine pathway and nigrostriatal pathway. The D1, D2 receptor versus the D3 receptor. We think that that's the probably the pathogenesis of the restless leg. So yeah, and I don't see the as much of a problem as Bill has with the Parkinson's disease. Because I'm mainly practice sleep medicine. And movement disorder, Bill, you see a lot of the restless leg associated with the other movement disorder?
Not really. I mean, I don't think there's any, to answer the question, I don't think there's any evidence that RLS becomes anything else. Many people with Parkinson's do have RLS-type symptoms that kind of come and go. They also have a number of other sensory symptoms and akathisia, and it can actually be kind of hard to tease that out. But I don't think there's any evidence that RLS becomes Parkinson's. In fact, there's some evidence that it may help prevent the onset of Parkinson's disease. And despite the fact that they both use dopaminergics, there's really been nothing pathophysiologically to connect the two.
Great. And Dr. Lee, I'll send this question to you. Do you find that patients with augmentation are the same patients who suffer from impulse control disorders related to their RLS therapy?
Yeah, I have seen quite a number of patients that have been on dopamine agonists for a period of time and start developing impulse control phenomenon. And as a matter of fact, we just put in a petition to the FDA because we're seeing the alarming increase in the impulse control and psychiatric diagnosis after the patient has been exposed to some of the dopamine agonists, almost like double the number of psychiatric diagnoses if we follow them a long period of time. And then we're looking at over 500,000 patients. And then this is a very, very large number of patients that we have been monitoring. And so, yes, the short answer is we do see that quite a bit.
Here's another question I'm going to push to the slide area. And Dr. Bookfear, let me start with you. What is the usual age group of patients diagnosed with RLS?
Well, the typical age group that gets diagnosed are in their 50s, 60s, maybe a little older, although especially patients who have a family history tend to have it when they're much younger. But since it's milder, they don't complain very much, and the symptoms kind of are strange symptoms, so the physicians usually don't twig on the diagnosis till they start having at least more severe ones, or severe enough that they're complaining, and the patients often will come up with a diagnosis. Although I think these days physicians are much more aware, but typically you're looking at the average patient in their 50s and 60s.
Thank you. Pulling the next question up now. Dr. Lee, I'll send this to you first. Is there any evidence supporting pushing the ferritin level above 100 or 150 for routine RLS or for augmentation?
Well, I have not pushed that high, and because if you get too much of the iron, just like any good things, too much can be harmful. And if it is too much of the iron, and then our body end up storing it in the liver, and it certainly can cause harm too. And so I usually call it Goldilocks theory, and I just kind of say, well, not too much, not too little, just right. So I usually kind of keep around, anything that less than 50 or 75, I replace it. And I just kind of keep it up, no higher than the 100 and 200, that kind of range. Yeah. And any other speaker can chime in too. Mark, you go any higher?
Yeah, I'll tell you what my experience is with this. Chris Early actually likes to push it above 200 to actually above 250 even. And what I've found, since I've been doing quite a bit of iron infusions, I have patients who get down to levels, let's say 130, 140 even, and they start complaining of restless leg symptoms coming back after they've received an iron infusion. Could be 3 months, 6 months, a year ago. And so what happens here is I give them more iron and they get better again. So I found even levels of 130, 140, maybe higher, for some patients may not be adequate. And remember, the serum iron only reflects what's in the serum, not what's in the brain, so it doesn't always correlate that well.
Thank you for those differing perspectives. Dr. Ondo, I'll send this one to you first. We talked about heat and vibrations helping with RLS. For this attendee, ice seems to numb the feeling for a few hours at a time. Are there any studies on this?
I'm not aware of one specifically on cold. Any sensory stimulation can improve RLS symptoms. Hot, cold, vibration, pain, and of course movement as well. So there have been various devices that are sold. They're usually either things that apply pressure to the feet or legs, or vibrating pads. Ice would be cheaper, I imagine, so I certainly would have no objection to using ice if that's the sensory stimuli that seems to work best for that person.
I've seen more patients that actually resort to using hot water, scalding hot water, actually, quite a number of them. They say that that's the only, relief they can obtain. And it was kind of pretty sad.
That is sad. I hope they were able to find an alternative eventually. And then one of our audience poll questions, it seemed that a lot of our audience said they had trouble differentiating between the natural progression of the disease versus actual augmentation. Dr. Bookfuhr, would you have any insights on how sleep clinicians can differentiate between those two?
I'll tell you, that can be very difficult because really what augmentation does is exactly what the natural progression of the disease does. A couple of things is if the worsening occurs not too long after starting the dopamine agonist, meaning several months, then it's easier to tie it together. But unfortunately, it can be several years, and what you see is you keep giving higher doses of the dopamine agonist and you get relief, but you have to keep doing that. So you kind of have to look back and say, what's happening? You keep having to give more and more of the dopamine agonist. Now, I can't say definitively that progression of the disease wouldn't do the same thing, but the best way to figure it out is if you get the patient off the dopamine agonist, if the RLS becomes much easier to control, then in retrospect, it was augmentation and not progression of the disease, which just would continue to be worse.
Thank you. And I'll send this to Dr. Lee. Another common problem that the audience has is differentiating between augmentation and just night-to-night variability of symptoms. Dr. Lee, can you shed any light on how to differentiate between augmentation and night-to-night variability?
Yeah, augmentation, I mentioned that using the criteria slide and then, especially they start going all the way to the trunk and upper extremities and then coming on much earlier in the day, by 2 to 4 hours. And usually those that are, patient that I consider is augmentation. And night-to-night variability, it's only changing very, very slightly. But augmentation, those patients are pretty problematic. They feel like that none of those medication, and the dose that they are taking actually getting worse instead of getting better. So Mark may be able to chime in to, speak on that too.
Yeah, no, there's kind of a big difference between night-to-night variability. Because patients will say, well, they're good some nights, not other nights, but they don't always have that earlier onset. And again, you just have to look at the different criteria. The augmentation is, very easy to pick up, especially as it becomes more severe, because it's happening every night. They're having more and more trouble, and they will demand an increase in, or something has to be done, an increase in their medication or something extra. Whereas the night-to-night variability could be due to many things, and most patients will put up with it. Now, I think it might be more difficult with very early augmentation, where it's very mild. You might see just some night-to-night variability, but sooner or later that will declare itself as being a daily type of thing.
Excellent. I'll send this next one to Dr. Ondo first. A lot of primary care physicians are the ones who at least will be the first to start treating a patient with augmentation or with restless-like syndrome in general. So do you have any advice for how you or how sleep clinicians can get the word out to primary care physicians about properly treating restless-like syndrome?
Yeah, as you heard, treating augmentation can be very challenging. I think there does need to be more education. When there were a number of companies marketing drugs for RLS, there was, I think, honestly, a lot more education for primary care physicians than there are now. When there's been less of that. So the other forums are important. I'm doing a talk at the American Geriatric Society in a couple months on RLS, but more needs to be done. I'm not sure a simple answer as far as how to facilitate that, though.
That makes sense. It is a challenging problem. And Dr. Ondo, can you weigh in on this next question? Does clonopin help with restless leg syndrome?
Yeah, so Klonopin and other benzodiazepines, for that matter, are relatively effective medicines to get people to sleep. They have been shown in studies to reduce the awakenings from periodic limb movements of sleep. There has never been a well-designed study that's shown benefit of any benzodiazepine in restless leg syndrome. We sometimes do use these medicines as adjunct therapy if we are treating RLS and they still have residual insomnia. We use this class of medicine sometimes, but I very rarely use them for RLS itself as monotherapy.
Thank you. Well, in order to finish on time today, I want to conclude by saying thank you to our three presenters, our sponsor, and to our audience members. Today's webinar is being recorded, so you may rewatch for free anytime using the same link you used to log on today. Feel free to share the link with colleagues who may have missed today's live event. Email me at sroy@medcore.com with comments, questions, and future webinar suggestions, and visit us at www.sleepreviewmag.com. Thank you for participating in this Sleep Review webinar.